Let's shift gears and move into one of the most clinically unforgiving organs we'll study this term, the heart. From a pathology standpoint, the heart is not very forgiving. It works constantly, has extremely high metabolic demands, and has very limited tolerance for injury. When something goes wrong here, there's very little margin for error, and that reality shows up clearly in histology. As histotechnologists, we don't just need to know what heart disease is, we need to understand why certain microscopic changes matter so much. A few damaged cardiomyocytes, a disrupted conduction pathway, or a small area of ischemia can translate into catastrophic clinical outcomes. Throughout this lecture, I want you thinking about one guiding question. If this tissue fails at the cellular level, what happens to the whole patient? That mindset, connecting structure, function, and consequence, is exactly what will make you strong in both the lab and on your board exam. Before we get into the the details, let's level set what you should be able to do by the end of this chapter. We'll start with a review of normal cardiac anatomy and physiology, because pathology only makes sense when you understand what normal looks like, both grossly and microscopically. You'll also learn how clinicians define cardiac death and sudden cardiac death, and why those definitions matter when we're interpreting autopsy findings or biopsy material. We'll connect clinical signs like shortness of breath, edema, murmurs, and pleural effusions to what's actually happening in heart tissue and downstream organs. You'll see how common diagnostic tools, ECGs, enzyme levels, echocardiograms, and catheterization relate back to structural or cellular changes in the myocardium and the vessels. Later in the chapter, we'll explore congenital heart defects, coronary artery disease, and myocardial infarction, as well as inflammatory and infectious conditions like myocarditis and endocarditis. And finally, how all of this ties into heart failure and cardiogenic shock. This chapter pulls together anatomy, physiology, pathology, and clinical medicine. So expect it to feel integrative. That's intentional. Now let's ground ourselves in structure, because orientation is everything, both at the bench and at the scope. What you're looking at here is a roadmap of blood flow through the heart. I want you to imagine this diagram the same way you'd imagine a complex specimen orientation during embedding. If you don't know where you are, nothing else makes sense. Blood enters the heart through the right atrium, moves to the right ventricle, and is pumped to the lungs for oxygenation. Oxygenated blood returns to the left atrium, moves into the left ventricle, and then is pumped out to the systemic circulation. Here's the key histology first takeaway. Each chamber has a different workload, and that workload determines wall thickness, cell size, and vulnerability to injury. The left ventricle does the heavy lifting. Its myocardium is thicker, more muscular, and far more metabolically demanding. That's why ischemic injury hits the left ventricle so hard, and why most myocardial infarctions show their most dramatic changes there. Valves, the chordae tendineae, and the papillary muscles may look like background players, but damage here can completely disrupt flow dynamics. Think of them like tension cables on a suspension bridge. Small failures can cause massive downstream collapse. As we move forward, keep asking yourself, where is the injury located? What structure is failing? And how would that failure appear histologically? That's the mindset that turns diagrams into diagnoses. Before we get anywhere near pathology, we have to be absolutely solid on normal blood flow through the heart. This is one of those foundational things that shows up everywhere, in exams, in diagnostics, and in understanding why disease progresses the way it does. So we're going to walk through this slowly and deliberately. Think of the heart like a two-sided pump with one-way doors. Blood only moves forward because valves open and close at exactly the right time. When those doors fail, chaos follows, and we'll see that later with valve disease and heart failure. At the top right, you're going to see two key terms: diastole, which is the filling phase, and the systole, which is the contraction phase. If you remember nothing else, remember this: diastole fills, systole pushes. From a histology standpoint, repeated filling and contraction is why cardiac muscle cells are striated, branched, and packed with mitochondria. These cells are built for endurance, but they pay a price when oxygen is limited. So let's walk through the pathway. So step 1, blood returns from the body into the right atrium through the superior and inferior vena cava. This happens during diastole, when the heart is relaxed. At this point, blood is oxygen poor. Histologically, this doesn't look different, but functionally, it matters tremendously. Step 2. Blood passes through the tricuspid valve into the right ventricle. This valve prevents backflow. If it fails, blood flows where it shouldn't, and pressure builds where it doesn't belong. That's how you get systemic congestion and edema. Step 3. During systole, the right ventricle contracts and pushes blood through the pulmonary valve into the pulmonary artery, sending it to the lungs. Notice the timing here. Contraction is doing real work. If myocardial cells are damaged, this step fails first. Step 4. Blood receives oxygen in the lungs. This is where cardiac and pulmonary pathology overlap. If lung tissue is compromised, or if pulmonary pressures are too high, the heart pays the price, especially the right ventricle. Step 5. Oxygenated blood returns to the left atrium via the pulmonary veins during diastole. This blood is now oxygen-rich and headed for systemic circulation. Step 6. Blood moves through the mitral valve into the left ventricle. This valve is under a lot of stress. It opens and closes against high pressure thousands of times a day. That's why mitral valve pathology is so common. Step 7. During systole, the left ventricle contracts and pushes blood through the aortic valve into the aorta. This is the most forceful contraction in the heart. Histologically, this explains why the left ventricle myocardium is thick and why ischemic injury here is so devastating. Step 8. Oxygenated blood is delivered to the body and the cycle repeats over and over and over. No breaks, no backups. From a histotechnologist's perspective, this flow explains patterns of injury, why ischemia hits the left ventricle hardest, why valve damage leads to pressure-related remodeling, why chronic stress causes hypertrophy before failure. Think of blood flow like traffic through a city. If one intersection fails, congestion spreads everywhere, and the tissue tells that story microscopically. If you can visualize this flow clearly, pathology starts to make sense instead of feeling random. This slide answers two deceptively simple questions that turn out to be everything in cardiac pathology. How does the heart feed itself? And how does it know when to beat? If either of these systems fail, the myocardium doesn't get injured slowly, it gets injured fast. The heart does not rely on the blood inside its chambers for oxygen or nutrients. That blood is just passing through. Instead, the myocardium is supplied by the coronary arteries. These are the right and left coronary arteries, and they originate directly from the aorta, immediately above the aortic valve. That location matters. Why? Because coronary blood flow happens primarily during diastole, when the aortic valve is closed and blood can flow back into the coronary ostia. During systole, those vessels are compressed by contracting myocardium. This explains several important things you'll see later. Why tachycardia reduces coronary perfusion, and why ischemia worsens when diastole is shortened, and even when myocardial cells are so vulnerable to even brief interruptions in blood flow. From a histology perspective, cardiac cells are metabolically demanding. They are packed with mitochondria and have very little tolerance for hypoxia. They don't store energy well, and they don't regenerate well. When coronary blood flow is reduced, injury is rapid and often irreversible. That's why coronary artery disease is such a big deal. Now let's talk about how the heart knows when to contract. The heart has its own intrinsic electrical conduction system, essentially a built-in pacemaker network. It begins with the sinoatrial or SA node. This node is located in the right atrium and sets the rhythm. It's the reason your heart keeps beating even if it's removed from the body briefly. Cardiac muscle is autorhythmic. From the SA node, the electrical impulse spreads across the atria and reaches the atrioventricular node, or the AV node. It pauses briefly. This pause is intentional and very important. Then it travels down the bundle of His, splits into right and left bundle branches in the interventricular septum, distributes through Purkinje fibers to coordinate ventricular contraction. That pause at the AV node allows the ventricles time to fill before they contract. Lose that coordination and efficiency plummets. Conduction fibers don't look like typical cardiac muscle. They're larger, they have fewer contractile filaments, they stain paler, and they're specialized for signal transmission, not force generation. As histotechnologists, this matters because conduction tissue can be subtle on slides. Ischemia in these regions can cause arrhythmias without massive infarction. Scarring or fibrosis in the septum can interrupt electrical flow. This is why some patients die suddenly without large, obvious myocardial infarcts. When either system fails, coronary artery blockage leads into ischemia, which leads into myocardial cell death and into scar formation. Okay? Electrical disruption is going to cause arrhythmias and sudden cardiac death. And here's the hard truth. Cardiac muscle repairs by fibrosis, not regeneration. Once those cells are gone, they're replaced with scar tissue that cannot contract or conduct electricity. That's why early intervention matters and why understanding the normal systems is critical before we talk about disease. If you remember nothing else from this slide, remember this. The heart feeds itself through the coronary arteries. The heart beats because of a precise electrical pathway. Damage to either system shows up in tissue, and the patterns are predictable if you know what you're looking at. And that's where histology becomes diagnostic, not just descriptive. Now that we understand how blood is supposed to move through the heart, we can talk about what happens when the doors don't work properly. Heart valves are essentially one-way doors. Their entire job is to open fully when blood needs to pass through, and then seal tightly to prevent backflow. When valves fail, they usually fail in one of two major ways. Incompetent or regurgitant valves. So an incompetent valve is a valve that fails to close completely during systole. Instead of blood moving forward efficiently, some of it leaks backward. This is called regurgitation. Think of it like a door that won't latch. You can push air through it, but it keeps slipping back behind you. From a physiologic standpoint, this means the heart has to pump extra volume, chambers upstream become dilated, and over time, the myocardial walls stretch and weaken. From a histology standpoint, incompetence is often related to valve leaflet thickening, fibrosis, chordae tendineae damage, and papillary muscle dysfunction. Important repair connection here is that valves have very limited healing capacity. Once they're deformed by fibrosis or calcification, they don't remodel back to normal. That's why valve disease tends to be progressive, not self-correcting. Then we have valvular stenosis. Stenosis is the opposite mechanical problem. Instead of failing to close, the valve fails to open fully. This is usually due to hardening, thickening, or calcification of the valve leaflets. Think of this like a door that's rusted shut. You can still force it open, but it takes a lot more pressure. Physiologically, stenosis causes increased resistance to blood flow, pressure overload on the chamber behind the valve, and hypertrophy of the myocardium as the heart works harder to push blood through a narrowed opening. Okay? Histologically, stenotic valves often show dense fibrosis, calcific deposits, thickened and rigid leaflets, and loss of normal layered architecture. This is where gross pathology and histology really intersect. What you see in the gross images on this slide, thickened, misshapen valves, has a microscopic correlation in collagen deposition, inflammation, and mineralization. Why this matters to you as a histotechnologist is this. Valve pathology isn't just about anatomy. It's about mechanics at the tissue level. When you're processing valve tissue, things to pay attention to include orientation of the leaflet, areas of calcification that might require decalcification, and fibrotic thickening that can obscure normal layers, and inflammatory changes that suggest underlying rheumatic or infectious processes. Poor fixation or sectioning can easily distort valve architecture, making pathology either subtle or exaggerated. And clinically, both incompetence and stenosis can lead to heart failure, arrhythmias, thrombosis formation, and sudden decomposition under stress. Decompensation under stress. So picture takeaway is valvular disease is not just a plumbing issue, it's a structural failure at the tissue level that forces the heart to adapt, sometimes temporarily, sometimes catastrophically. And once that adaptation crosses a certain threshold, repair turns into permanent remodeling. That concept, adaptive versus irreversible damage, should feel very familiar by now. At this point, we've reviewed how the heart is built, how blood flows, and how valves can fail. Now we zoom out and ask the question, the obvious but uncomfortable question. What actually goes wrong most often? And what kills people? The answer overwhelmingly starts with atherosclerosis. Atherosclerosis is the most common cause of death in the United States, and almost every cardiac event on this slide traces back to it in some way. This is not an acute disease. It's slow, progressive, and quiet, until it suddenly isn't. At the tissue level, atherosclerosis is fundamentally a disease of endothelial injury, lipid accumulation, chronic inflammation, and fibrous cap formation. From a histology perspective, this is a classic example of maladaptive repair. The vessel wall tries to heal repeated injury, but instead of restoring normal architecture, it builds something rigid, narrowed, and unstable. Once coronary arteries are narrowed or occluded, several things can happen. Myocardial infarct. So if blood flow drops below what cardiac muscles can tolerate, myocardial cells die. Remember, cardiac myocytes have very limited regenerative capacity. Necrosis here means permanent loss. Histologically, this progresses from coagulative necrosis, inflammatory infiltration, granulation tissue, and then fibrous scar. That scar doesn't contract. It doesn't conduct electrical signals normally, and it changes how the heart functions forever. Arrhythmias. Scar tissue and ischemic myocardium disrupt the electrical pathways. This is why someone can survive an MI, myocardial infarct, and still die suddenly later from a fatal arrhythmia. From a microscopic standpoint, conduction abnormalities often correlate with fibrosis, myocyte loss, altered gap junctions, and structure and function are inseparable here, okay? Angina pectoris. So angina is ischemia without infarction. The tissue is alive but undersupplied. Think of this as a warning light. The myocardium is telling you, I'm not getting enough oxygen, but I'm not dead yet. Histologically, angina may show minimal permanent damage early on, but chronic ischemia drives adaptive hypertrophy, which can later become maladaptive. And then congestive heart failure. Over time, repeated injury, scarring, and pressure overload weaken the heart's ability to pump. Heart failure isn't one event, it's the end result of cumulative structural damage. This is where you start seeing chamber dilation, wall thinning or hypertrophy, increased interstitial fibrosis. Again, this is repair gone wrong. And cardiac death. Whether through infarction, arrhythmia, or pump failure, atherosclerosis sits at the root of most cardiac deaths. Not dramatic, not sudden at first, just relentless. On the other side of this slide is hypertensive heart disease, the second most common cardiac problem. This one works differently. Instead of blocked arteries, the problem is chronic pressure overload. The heart responds the only way muscle knows how. It gets bigger. Some key features are it usually affects older individuals, and it's not rapidly fatal, and it develops slowly over years. So histologically, chronic hypertension leads to myocyte hypertrophy, increased connective tissue, and reduced compliance. Initially, this is an adaptive response. Eventually, it becomes a liability. A stiff, hypertrophied heart feels poorly, oxygen demand increases, and failure follows. Big picture takeaway is both atherosclerosis and hypertensive heart diseases are examples of the same core concept. The heart adapts to stress until it can't. As histotechnologists, you are often looking at the physical record of that failed adaptation: fibrosis, hypertrophy, necrosis, and scar. Your slides tell the story long after the clinical event has passed. So far, we've discussed heavily on acquired diseases like atherosclerosis and hypertension. This slide reminds us that not all serious heart disease develops over decades. Some patients start life with structural or functional disadvantages built right into the heart. Let's walk through these one at a time and keep our eyes on structure, flow, and consequence. So, congenital heart disease. Congenital heart disease refers to structural deformities present at birth that alter normal blood flow. These can include septal defects, abnormal vessel connections, valve malformations, and abnormal chamber size or orientation. From a functional standpoint, these defects create abnormal pathways for blood flow, often leading to mixing of oxygenated and deoxygenated blood, pressure overload in certain chambers, or even compensatory hypertrophy. Histologically, what you often see later in life isn't the original defect, it's the downstream remodeling, such as chamber dilation, myocyte hypertrophy, and fibrosis from chronic stress. This is a recurring theme. The heart adapts to abnormal flow patterns, but those adaptations come at a cost. We have rheumatic heart disease. Rheumatic heart disease is a classic example of inflammation leaving permanent scars. It begins with an immune response, typically following a streptococcal infection, and ends with chronic inflammation, fibrosis, and valve thickening and fusion. Histologically, valves affected by rheumatic disease show fibrous thickening, distorted architecture, and reduced flexibility. Valves are supposed to be thin, smooth, and mobile. Scar tissue turns them stiff and irregular, a perfect setup for stenosis, regurgitation, or both. This is repair gone wrong. The body heals inflammation with fibrosis, but fibrosis permanently alters function. And we have chronic lung disease in the form of cor pulmonale. Here's where cardiac pathology reminds us that organs do not fail in isolation. So chronic lung disease increases resistance in the pulmonary circulation. That increased pressure is transmitted directly to the right side of the heart. The result is cor pulmonale, right-sided heart failure secondary to lung disease. Histologically, the right ventricle shows hypertrophy, eventual dilation, and reduced contractile efficiency. Again, this starts as adaptation. The heart thickens to push against higher pressure. Eventually, the muscle fatigues. Sudden cardiac death is most often caused by ventricular fibrillation, a chaotic electrical state where the heart muscle quivers instead of contracting. The key word here is uncoordinated. The myocardium is still alive, but electrical signals are disorganized, contraction is ineffective, and the cardiac output drops to zero. Histologically, we may not see dramatic changes if death is rapid. This is one of those cases where function fails before structural visibility does. A humbling reminder that histology doesn't always tell the whole story. And lastly, hypertrophic cardiomyopathy. This condition is uncommon, but it's critical to recognize because of who it affects. Hypertrophic cardiomyopathy is usually a genetic defect involving abnormal thickening of the intraventricular septum. The muscle isn't just thick, it's disorganized. Histologically, you'll see myocyte hypertrophy, fiber disarray, abnormal architecture that disrupts both contraction and conduction. This disorder is notorious for causing sudden death in young athletes, often during exertion when oxygen demand is high and outflow obstruction becomes catastrophic. Big picture takeaway is that every condition on this slide reinforces one core principle. Structure determines flow. Flow determines stress, and stress determines failure. Whether the cause is congenital, inflammatory, pulmonary, or electrical, the heart responds the same way. It adapts, it remodels, and eventually it may decompensate. As histotechnologists, you are often the first to see the architectural evidence of that story, sometimes years after it actually began. This slide is where structure, physiology, and patient experience finally collide. Symptoms are not random. They are the clinical expressions of microscopic events happening in the myocardium, vessels, and the surrounding tissues. So let's start with the big one, myocardial infarction, or often referred to as just an MI. A myocardial infarction occurs when blood flow through a coronary artery is reduced or completely blocked, leading to ischemia and eventually necrosis of cardiac muscle. Classic symptoms, which are more common in men, are the hallmark symptom is severe persistent chest pain with a squeezing or pressure-like quality. Why squeezing? Because ischemic myocardium switches to anaerobic metabolism. It accumulates lactic acid and activates pain fibers. That metabolic distress is what patients feel. Pain often radiates to the left shoulder, the arm, neck, or jaw. This is referred pain, caused by shared spinal nerve pathways between the heart and those regions. A histology tie-in is that early MI tissue may still look deceptively normal, but function is already failing. Structural damage lags behind symptoms. We have atypical MI symptoms, which are especially in women. This is critical. Many patients, particularly women, do not present with classic chest pain. Instead, they may experience no obvious symptoms at all, vague fatigue, shortness of breath, and generalized weakness. From a pathology perspective, the myocardial injury can be just as severe. The difference is how the nervous system interprets and reports the injury. This is one reason MIs are sometimes discovered retrospectively when scar tissue is found on imaging or histology. Then we have the angina pectoris. So angina is transient ischemia, not infarction. Blood flow is temporarily insufficient, often during exercise or emotional stress, but not long enough to cause permanent cell death. Histologically, there's no necrosis, no scarring, but repeated episodes can prime the tissue for future infarction. Think of angina as the heart saying, I'm underpowered right now. Fix this before something breaks. And then congestive heart failure, or CHF. Heart failure is less about sudden injury and more about chronic inability to move blood forward efficiently. When the heart can't keep up, blood backs up and fluid leaks out. This leads to pulmonary edema, which is fluid in our alveolar spaces, ascites, which is fluid accumulation in the peritoneal cavity, peripheral edema, swelling of the legs, and the histology connection is that in the lungs we may see edematous alveoli, congested capillaries, hemosiderin-laden macrophages, which are also known as heart failure cells. This is where cardiac disease literally shows up in other organs. So big picture takeaway is that symptoms are not just patient complaints. They are functional readouts of tissue level pathology. Chest pain reflects ischemic metabolism. Shortness of breath reflects fluid accumulation. Edema reflects hydrostatic pressure failure. As histotechnologists, understanding this link helps you recognize why subtle changes on a slide can correspond to dramatic clinical consequences. This slide is about how clinicians connect symptoms to structure before tissue ever reaches the lab. Every test on this list is asking some version of the same question. Is the heart working the way its tissue is built to work? The physical exam is the most basic diagnostic tool, but it's surprisingly powerful. Using a stethoscope, clinicians listen for heart murmurs, which often indicate turbulent blood flow, fluid sounds, especially in cases of heart failure. From a pathology standpoint, murmurs often trace back to valvular stenosis, valvular incompetence, or structural deformities. Those abnormal sounds are the audible results of microscopic and gross anatomic changes in valves and chambers. Arterial blood pressure. Blood pressure is measured using a sphygmatometer, but conceptually it reflects vascular resistance and cardiac workload. Chronically elevated blood pressure means the myocardium is pushing against increased resistance. Histology tie-in is that over time this leads to myocardial hypertrophy, thickened ventricle walls, and eventually decreased compliance and heart failure. Pressure leaves fingerprints on tissue. Cardiac catheterization is a more invasive but very precise test. A catheter is threaded through the blood vessels and into the heart to measure intracardiac pressure. It delivers contrast dye for angiograms, and those angiograms visualize the coronary artery narrowing, Obstructions from atherosclerosis. From a histology perspective, this test helps localize where ischemic injury is likely to occur, guiding what tissue changes may already be developing or about to develop. Endocardiography, or I'm sorry, echocardiography. Echocardiography uses ultrasound to produce a real-time image of the beating heart. This allows clinicians to assess chamber size, wall motion, valve function, and even ejection fraction. While we don't see cells here, we see functional consequences of cellular changes, such as stiff ventricles, poor contractibility, and abnormal valve movement. Think of echo as function, histology as structure, two sides of the same coin. And then we have electrocardiography, or ECGs. These measure the electrical activity of the heart. It reflects the conduction pathways, rhythm abnormalities, and areas of ischemia or infarction. Electrical disruption often precedes visible structure damage, but persistent abnormalities usually correspond to underlying myocardial injury or scarring. That's why arrhythmias and infarcts are so closely linked. Stress tests assesses how well the heart performs under increased oxygen demand. If coronary arteries can't deliver enough oxygen, ischemia becomes evident, and symptoms and ECG changes appear. Histology connection here is that repeated stress-induced ischemia can prime myocardium for infarction, even if tissue initially appears intact. Enzyme tests, this is where we get biochemical, and this is where histology and lab medicine really intersect. Troponin is the most specific marker for myocardial injury. It is released when cardiac muscle cells are damaged or dying. Creatine phosphokinase, or CK, rises with muscle injury but is less specific. These enzymes are molecular evidence that cells have lost membrane integrity, even before gross necrosis is visible. And lastly, we have the brain natriuretic peptide, or BNP. BNP is released when cardiac muscle fibers are stretched, as in congestive heart failure. That stretch reflects volume overload, chamber dilation, and decreased pumping efficiency. Histologically, this corresponds to dilated chambers, thin or hypertrophied myocardium, and secondary changes in lungs and liver. Big picture takeaway here is that each test on this slide answers a different question: structure, function, electrical activity, biochemical injury. Together, they build a roadmap that helps explain what we eventually see on tissue sections. As histotechnologists, understanding these tests help you interpret why a specimen looks the way it does, not just what it looks like. Okay, this slide is a pivotal point in the lecture. Up to now, we've mostly been talking about acquired heart disease, things that happen to a heart over time: plaque buildup, pressure overload, inflammation, injury, and repair. Genetic and developmental heart diseases are different. These are conditions where the heart's blueprint was altered before birth. Think of it this way: most cardiac disease is wear and tear. Congenital heart disease is a construction issue. During embryonic development, the heart loops, septates, forms valves, and aligns great vessels. If something goes wrong at any step, blood flow pathways can be misrouted, narrowed, or mixed. From a histology perspective, the tissue may look normal at the cellular level early on, but it's arranged in the wrong place, orientation, or proportion. Structure drives function. Now, why this matters for histotechnologists is, even though many congenital defects are diagnosed clinically or surgically, tissue still tells the story. Chronic hypoxia leads to myocardial hypertrophy. Abnormal flow creates endothelial stress. Pressure overload alters muscle fiber thickness and organization. Long-term compensation eventually leads to failure and fibrosis. You're often seeing the downstream consequences of a developmental problem that's been present for years. In congenital heart disease, you may encounter thickened ventricular walls from chronic workload, dilated chambers from volume overload, fibrosis due to long-term ischemia or strain, and secondary lung changes when pulmonary circulation is affected. The heart adapts the only way it knows how, again, by remodeling. But again, remodeling has limits. Think of congenital heart disease like plumbing installed incorrectly in a building. The pipes themselves may be intact, The water still flows, but it flows in the wrong direction, under abnormal pressure, and into spaces that weren't designed for it. Over time, even good pipes fail if the system design is flawed. And keep this in mind, not all congenital heart disease presents in infancy. Some individuals don't become symptomatic until adolescence or adulthood. This is especially important when we talk about sudden cardiac death in young athletes, hypertrophic cardiomyopathy, and undiagnosed structural abnormalities. Bodies compensate differently, and not everyone follows the textbook timeline. A fun but useful fact here is the heart is the first functional organ to develop in the embryo. That means it's incredibly resilient, but also incredibly sensitive to developmental timing errors. Small changes early on can have lifelong consequences. This is the most common congenital heart defect, and it's a great example of how a small structural change can have big downstream effects over time. Normally, the aortic valve has three cusps. In a bicuspid aortic valve, there are only two. That may not sound dramatic, but in the heart, symmetry matters, because structure equals function. With only two cusps instead of three, the valve doesn't open as smoothly. Blood flow becomes more turbulent. The valve experiences uneven mechanical stress. Over years and decades, that stress accelerates. Calcification, thickening, stenosis. So while this defect is present at birth, the pathology often shows up much later. Many individuals with bicuspid aortic valve are asymptomatic for years. The heart compensates. The left ventricle works harder, muscle fibers hypertrophy, and cardiac output is maintained for a while. Eventually, compensation reaches its limit. This is why symptoms often appear in adulthood rather than childhood. On histologic sections or gross specimens, you may see thickened valve leaflets, fibrosis and calcific deposits, reduced valve openings, and secondary left ventricular hypertrophy. Remember, the myocardium is responding to chronic pressure overload. This is adaptation turning into pathology. Some manifestations, we may present with easily fatigued, so reduced forward blood flow, a murmur of aortic stenosis, so turbulent flow through a narrowed valve, fainting, or also called syncope, transient drops in the cerebral perfusion, heart failure, so long-term ventricular strain and remodeling. Each symptom traces back to altered mechanics at the valve level. Think of a bicuspid aortic valve like a door designed to swing open evenly, but one hinge is missing. At first, you can still open the door, but over time, the frame warps, the hinges wear out, and the door becomes harder to move. Eventually, the whole system fails. An important professional note here is that bicuspid aortic valve is often incidentally discovered during imaging, surgery, or autopsy. As histotechnologists, you may be processing valve tissue, seeing secondary myocardial changes, supporting diagnoses that explain years of unexplained symptoms. Your tissue sections help complete the clinical story. This slide reinforces a core concept for this course. Congenital does not mean immediately catastrophic, but it often means inevitable change over time. Structure drives flow, flow drives stress, stress drives remodeling, and remodeling always leaves a histologic fingerprint. This slide is all about pressure gradients and what happens when the walls that are supposed to separate them fail. If you understand pressure, you understand septal defects. So let's start with the atrial side. The foramen ovale is a normal fetal structure. Before birth, it allows blood to bypass the lungs, which makes sense because fetal lungs aren't doing gas exchange yet. After birth, when the lungs inflate, the pressure shifts, the foramen ovale should close. When it doesn't, we get a persistent atrial septal defect. Functional consequences of this are the blood moves from high pressure left atrium to low pressure right atrium. This creates increased volume and workload on the right side of the heart. Increased pulmonary blood flow. Symptoms may be subtle early on, but chronic overload matters. Over time, you may see right atrial and right ventricle dilation, hypertrophy due to volume overload, and secondary changes in pulmonary vasculature. Again, structure, flow, remodeling. Okay? Then we have ventricular septal defects, or VSD. These are where the stakes are higher. A ventricular septal defect is a hole in the intraventricular septum, and this is a much more serious problem. Why? Because the pressure difference is much greater. Pressure drives the pathology, right? Blood is forcefully pushed from high pressure left ventricle into the low pressure right ventricle. This results in inefficient systemic circulation, oxygenated blood being wasted back into the pulmonary circuit, reduced oxygen delivery to the body. This is why VSDs tend to present earlier and more severely. Microscopically and grossly, you may see marked ventricular hypertrophy, thickened myocardial fibers responding to pressure overload, and progressive heart failure changes if untreated. The myocardium is essentially working overtime, constantly. Think of septal defects like a hole in a shared wall between two rooms with different air pressures. Air, or blood, will always move toward low pressure, whether that movement is helpful or not. The body doesn't get to choose the direction. Physics wins every time. Clinical takeaways for histotechnologists is that septal defects may be diagnosed in infancy, discovered incidentally, or recognized only after long-term cardiac remodeling. Your tissue sections may show the consequences of abnormal flow, not just the defect itself. So understanding the why behind the changes makes your work more meaningful and more accurate. Key takeaway is that septal defects are not just holes. They are chronic flow problems with predictable histologic outcomes. Pressure differences drive flow, flow drives workload, workload drives remodeling, and remodeling always leaves evidence in the tissue. This slide is one of those everything connects moments in cardiac pathology. The tetralogy of Fallot isn't four random defects. It's one developmental problem that creates four predictable structural changes, and all of them revolve around misdirected blood flow. Tetralogy of Fallot is the most common cause of cyanotic congenital heart disease. Cyanotic equals blue. Blue equals poor oxygenation, and poor oxygenation equals blood is bypassing the lungs. The last part is the key. In tetralogy of Fallot, blood is pumped from the right side of the heart directly into systemic circulation without going through the lungs first. So oxygen-poor blood ends up supplying tissues that expect oxygen-rich blood. The body notices, and it notices quickly. Now let's walk through these as a cause and effect chain rather than a list. These are the four components of the tetralogy. So number one, shift in position of the aorta, or also referred to as overriding aorta. The aorta is positioned so it straddles both ventricles instead of sitting cleanly over the left ventricle. This allows blood from the right ventricle to enter systemic circulation. Think of it as a doorway that's no longer aligned with the correct room. Number two, narrowing of the pulmonary outflow tract, also called pulmonary stenosis. This creates resistance to blood leaving the right ventricle and entering the lungs. When the lungs become the harder route, blood will find another way out, and it does. Ventricular septal defect, or VSD, this hole between ventricles becomes the escape hatch. Because pulmonary outflow is restricted, blood moves from the right ventricle across the VSD and into the overriding aorta. This is the major region that oxygen-poor blood bypasses the lungs. Right ventricular hypertrophy, this one is a response, not the original problem. The right ventricle is pumping against increased resistance. It works harder, thickens over time. Histologically, this looks like myocyte hypertrophy, increased wall thickness, reduced chamber compliance. The heart is adapting, but again, at a cost. Why cyanosis happens? This is because blood that has not been oxygenated enters the systemic circulation. It lowers the arterial oxygen levels, produces the classic blue discoloration of skin and mucosa. This is not subtle, and it's often evident very early in life. In tissue sections, tetralogy of Fallot doesn't give you a single signature slide. Instead, you see right ventricular hypertrophy, chronic hypoxia-related changes, and secondary effects in multiple organs over time. This is a system-wide disease, not just a heart problem. Imagine a building where the emergency exit, pulmonary outflow, is blocked. A wall between rooms has a hole, and the main hallway or the aorta sits in the wrong place. People will take the fastest exit, not the safest one. Blood does the same thing. Many patients today survive tetralogy of Fallot due to early surgical intervention, but you may still encounter corrected anatomy, residual hypertrophy, and long-term remodeling changes. Understanding why those changes exist makes you a stronger dietitian. Tetralogy of Fallot is a disease of misrouted flow, and the histology tells the story of adaptation to chronic hypoxia. Again, structure determines flow, flow determines oxygenation, and oxygenation determines survival. And every one of those steps leaves evidence in the tissue. This slide organizes tetralogy of Fallot the way pathologists think. The cause leads to structural lesions, leads to functional consequences, and then clinical manifestations. That sequencing matters because tissue never changes randomly. The tetralogy of Fallot begins as an embryologic defect during cardiac development. Scientifically, there's abnormal development of the outflow tract and septation of the heart. So this is not degenerative, inflammatory, or infectious. It's a construction problem, not a wear and tear problem. And when construction goes wrong early, the entire system has to compensate. The 4 structural abnormalities. These are the same 4 components we just walked through, but now framed as lesions you might encounter in gross or imaging contexts. So the overriding aorta. The aorta sits over both ventricles instead of being cleanly aligned with the left ventricle. Functionally, oxygen-poor blood gains access to systemic circulation. Histologically, you won't see this in isolation on the slide. This is a gross anatomic relationship problem. Pulmonary stenosis, narrowing of the pulmonary outflow tract restricts blood flow to the lungs. This is the lesion that drives the right to left shunt. Less blood reaching the lungs equals less oxygen available. The VSD provides the physical opening that allows blood to move between ventricles. Because pressure is higher on the left, blood preferentially moves in ways that bypass oxygenation. This defect is often large and non-restrictive to tetralogy. The right ventricular hypertrophy is a secondary change, a response to chronic increased workload. Histology-wise, we would see enlarged cardiomyocytes, increased wall thickness, and reduced chamber compliance over time. This is classic adaptive pathology that eventually becomes maladaptive. Now we move from structure to symptoms, and every one of these makes sense once you follow the flow. So murmurs, which is caused by turbulent blood flow, especially across the narrowed pulmonary outflow tract. Remember, murmurs are sound evidence of abnormal flow, not a diagnosis by themselves. Cyanosis, result of chronic hypoxemia, oxygen-poor blood entering systemic circulation. This is the hallmark feature and often what leads to early detection. Retarded growth. Chronic hypoxia affects metabolism, tissue development, and energy availability. So growing bodies need oxygen. When they don't get enough, the growth slows. And lastly, heart failure over time. Right ventricular hypertrophy, reduced efficiency, increased myocardial oxygen demand, and eventually compensation fails. This is where congenital disease transitions into chronic heart failure pathology. Tetralogy of Fallot teaches us an important principle. Structure determines flow, flow determines oxygenation, and oxygenation determines tissue health. As histotechnologists, your role is often downstream, examining tissue that has adapted, compensated, and eventually decompensated. Understanding why those changes exist is what elevates your interpretation. This is a plumbing system built with a misaligned main pipe, a narrowed outlet, a hole between chambers, and a pump working overtime. The system still runs, but inefficiently and at a cost. Even with modern surgical correction, you may encounter residual hypertrophy, altered myocardial architecture, and long-term remodeling changes. And this slide helps you recognize where those changes started. Coarctation of the aorta is another example of how one structural narrowing can disrupt the entire cardiovascular system. This is not a subtle lesion, it's a fixed bottleneck in the thoracic aorta. Coarctation is a narrow, fibrous constriction of the thoracic aorta, most commonly just distal to the origin of the left subclavian artery. Think of it as a permanent kink in the main highway, one lane instead of four, no detour signs provided. Blood can get through, but not efficiently. This slide is all about pressure gradients. Proximal to the coarctation, this includes head, neck, upper extremities. Because blood is backing up before the narrowing, blood pressure is elevated. The left ventricle works harder to push blood forward. Histologically, that chronic pressure overload leads to left ventricular hypertrophy, so enlarged cardiomyocytes with increased wall thickness. Distal to the coarctation, this includes the abdomen, kidneys, and lower extremities. After the narrowing, blood pressure drops. Tissues receive less perfusion. This imbalance is why patients can have hypertension in the arms, but weak pulses in the legs. Everything listed here follows logically from that pressure mismatch. So decreased femoral pulse. This is a classic physical exam finding. Upper body should have strong pulses, lower body would have weak or delayed pulses. Same heart, same beat, just different delivery, right? Hypertension in the upper extremities. Chronic high pressure above the narrowing can lead to headaches, nosebleeds, and increased risk of vascular damage. This is often how coarctation is discovered in adolescents or young adults. A murmur, again, is the turbulent flow across the narrowed segment that creates audible murmurs, sometimes best heard over the back or left chest. So remember, turbulence equals sound. And heart failure. Over time, the left ventricle compensates, then decompensates. This is another example of adaptive hypertrophy becoming maladaptive. You won't diagnose coarctation on a routine myocardial H&E. What you will see downstream is hypertrophy cardiomyocytes, increased myocardial oxygen demand, and possible ischemic changes if compensation fails. Understanding the anatomy explains why those changes exist. Imagine watering a garden with a hose that's pinched in the middle. Before the pinch, pressure builds up. After the pinch, barely enough water reaches the plants. Same hose, same source, one critical narrowing. Why this matters for histotechnologists is even after surgical correction, patients may show residual hypertrophy, vascular remodeling, long-term pressure-related changes. Knowing the original lesion helps you interpret the tissue you're looking at years later. Coarctation of the aorta is a pressure problem created by a structure problem, and pressure problems always leave histologic footprints. Hypertrophic cardiomyopathy is a great reminder that bigger does not mean better when it comes to muscle, especially cardiac muscle. This is a genetic disease of the sarcomere, not a response to workload like hypertension. HCM is an autosomal dominant disorder, meaning only one altered copy of the gene is needed. It often runs in families. It can show up in young, otherwise healthy individuals. This is why it gets so much attention in young athletes and sudden cardiac death. The hallmark feature is a severely thickened interventricular septum. But this isn't just extra muscle. The muscle is disorganized. Fibers don't line up normally, and the tissue is stiff and inefficient. So even though the heart looks strong, it doesn't behave that way. Look at the diagram on the right. During diastole or filling, the thick septum limits how much blood can enter the ventricle. Less room equals less preload. During systole or pumping, the septum can obstruct outflow. The blood struggles to leave the left ventricle, so patients get less blood to the body, even though the heart is contracted. Think of this like a gym doorway that's been narrowed by someone stacking weight plates in the middle. You might be strong enough to push through, but traffic slows, people trip, and eventually someone gets hurt. Under the microscope, HCM shows myofiber disarray. Instead of neat, parallel cardiac muscle fibers, you'll see chaotic, crisscrossing myocytes, interstitial fibrosis, and abnormal electrical conduction pathways. This disorganization explains arrhythmias, which are a major cause of sudden death. Everything listed here as manifestations makes sense when you think histologically. So sudden death, often due to ventricular arrhythmias, electrical instability from disorganized muscle. This can occur without warning, even at rest or during exercise. Arrhythmia or infarction in the septum. The thickened septum has high oxygen demand, which may outgrow its blood supply. So ischemia plus fibrosis plus electrical chaos equals a dangerous rhythm disturbance. So important distinction for students is that this is not the same as hypertrophy from hypertension. Hypertension is adaptive hypertrophy and then organized muscle. HCM is a genetic defect with disorganized muscle. Same word, but very different disease, right? So as histotechnologists, we will see unexplained myocardial fibrosis, fiber disarray, and septal thickening without coronary disease. You should be thinking cardiomyopathy, not just big heart. Your ability to recognize these patterns helps pathologists connect tissue to cause. In hypertrophic cardiomyopathy, the problem isn't strength, it's structure, organization, and electrical stability. So up to this point, we've been talking mostly about structural congenital problems, issues people were born with or inherited. Now we shift gears. This section focuses on heart diseases that develop over time, often as a result of inflammation, infection, immune responses, or wear and tear changes. In other words, these conditions where tissue injury and repair go wrong. Big picture shift. Instead of asking, was this valve formed correctly? Is the septum in the right place? We're now asking, what happened to this tissue? Who showed up? How long did they stay? And what did they leave behind? That's classic pathology and very much histology driven. Why this category matters is that inflammatory and degenerative heart diseases are common, are often acquired, frequently show distinct microscopic changes before severe clinical symptoms appear. This is where inflammation, fibrosis, necrosis, calcification all start telling a story under the microscope. As histotechnologists, your role becomes even more critical here. These diagnoses often depend on identifying inflammatory infiltrates, recognizing chronic versus acute changes, distinguishing normal aging from true pathology, preserving delicate structures like valves and myocardium. Small processing or staining differences can change how clearly those features are seen. Think of congenital heart disease like a house built with a faulty blueprint. Inflammatory and degenerative disease is a house that had water damage, was patched repeatedly, and now has warped floors and cracked walls. Same structure, very different story. So in this section, we'll look at diseases driven by infection, conditions caused by immune-mediated inflammation, and degenerative changes that alter valves, myocardium, and conducting systems. At every step, we'll connect clinical presentation to the gross findings to the histologic findings. Just remember that inflammatory and degenerative heart diseases aren't about how the heart was built. They're about how it responded to injury over time. This is where pathology truly bridges cause, structure, and consequence. Okay, this slide is where everything starts to come together. Coronary artery atherosclerosis is the most common underlying cause of ischemic heart disease, myocardial infarction, and a whole cascade of downstream cardiac problems. If you understand this process, a lot of cardiopathology suddenly makes sense. The two big contributors here are atherosclerosis and hypertension. Think of hypertension as the constant high-pressure water flowing through old pipes. Over time, that pressure damages the endothelial lining, making it easier for lipids and inflammatory cells to sneak into the vessel wall. This is not an overnight problem. It's a slow, progressive injury. Let's focus on the coronary artery itself. Narrowing of the coronary artery means as plaque builds within the intima, the lumen gets smaller. Blood flow becomes limited, especially during times of increased demand, like exercise or stress. Then we have deterioration of the atherosclerotic plaque, which results in thrombus formation. Plaques are not stable forever. When a plaque ruptures, it exposes underlying material that triggers clot formation. And these may lead to myocardial infarction, or MI. Once blood flow is blocked long enough, cardiac muscle becomes ischemic and then necrotic. This is where pathology goes from chronic to acute very quickly. Under the microscope, atherosclerosis is very recognizable. We have a thickened intima, lipid cores with cholesterol clefts, foam cells, which are macrophages full of lipid, and we would see fibrous caps. When a thrombus forms, you'll see layers of fibrin, platelets, entrapped red blood cells. That cross-section image on the slide is a classic example. Yellow plaque narrowing the lumen with a red granular thrombus sitting right on top of it, essentially acting like a cork. Clinically, this can present in a few different ways. Again, angina pectoris, so transient ischemia, the heart is asking for more oxygen than it's getting. An abnormal electrocardiogram, so electrical activity changes when myocardial cells are stressed or injured. Myocardial infarction, which can include chest pain, elevated cardiac enzymes, abnormal ECG, arrhythmias, or even shock or heart failure in severe cases. Not all MIs look dramatic. Some are subtle, especially in certain populations, but the tissue damage is very real. Even when patients survive the acute event, the story doesn't end. Scar formation replaces contractile myocardium, pumping efficiency decreases, arrhythmias become more likely, and chronic heart failure may develop. Once cardiac muscle is lost, it does not regenerate. It heals by fibrosis. So think of coronary arteries like delivery roads to the heart muscle. Atherosclerosis is gradual road narrowing. A thrombus is a sudden roadblock. The heart muscle downstream doesn't care why the delivery stopped, it just knows it didn't get oxygen. A key takeaway, coronary artery atherosclerosis is a chronic inflammatory disease that can suddenly become an acute, life-threatening event when plaque ruptures and thrombosis occurs. From a histology standpoint, this is a disease where structure explains symptoms and microscopic findings explain the clinical outcome. Now, this slide shifts us from pathology to intervention, but as histotechnologists, we're still very much in familiar territory because intervention changes tissue and tissue tells the story afterward. So what is angioplasty? In angioplasty, a catheter with a tiny inflatable balloon at its tip is threaded through the vasculature and positioned right at the site of coronary artery narrowing. When the balloon is inflated, the atherosclerotic plaque is compressed. The lumen diameter increases and blood flow is immediately improved. Think of this like pressing your thumb into a dented drinking straw to open the channel back up. The straw still has damage, but fluid can move again. Now, what is a stent? A stent is essentially a tiny wired scaffold placed inside the artery to keep that newly opened lumen from collapsing again. So once deployed, the stent stays in place permanently, it braces the arterial wall outward, and it reduces the risk of immediate reocclusion. Some stents are drug-eluting, slowly releasing medications that suppress smooth muscle proliferation and reduces restenosis, which is very relevant when we think about healing processes at the tissue level. Angioplasty and stenting are controlled injuries. At the microscopic level, these procedures will disrupt the endothelium, compress intimal plaque, stretch and sometimes damage the media. After stent placement, the vessel undergoes healing. So we'd see endothelial regeneration, smooth muscle cell migration, and then possible neo-intimal hyperplasia. This is why restenosis can occur. The body is doing what it always does. repair, sometimes a little too enthusiastically. The image on the left shows cross sections of a coronary artery. One side demonstrates severe plaque narrowing. The other shows the stent holding the lumen open. That metallic structure doesn't disappear in tissue processing. It dramatically alters how the vessel looks grossly and histologically. If you were examining post-intervention tissue, you'd expect distorted vessel architecture, foreign material presence, and chronic inflammatory changes around the stent struts. A fun but useful analogy: think of plaque like drywall bulging into a hallway. Angioplasty knocks it back. The stent is the metal framing installed so the wall doesn't cave in again. The hallway works, but the wall will never be normal again. Stenting versus angioplasty restores blood flow, but it does not reverse atherosclerosis. It manages its consequences. For histotechnologists, this matters because post-intervention tissue is not normal tissue. Healing responses can complicate interpretation. Prior procedures leave permanent histological footprints. As you move forward, always ask, what did the vessel look like before intervention? What mechanical and inflammatory changes were introduced? And how would this affect what I see under the microscope? If you're thinking that way, you're already functioning at an upper division diagnostic level. Now, this is the reroute the traffic solution for coronary artery disease. When a coronary artery is so narrowed or damaged that angioplasty or stenting isn't enough, surgeons create an entirely new pathway for blood to reach the myocardium. In a coronary artery bypass graft or CABG, a segment of saphenous vein from the leg or internal thoracic artery is harvested and used to divert blood flow around a blocked or severely narrowed coronary artery. Instead of trying to fix the damaged road, we build a detour. Blood is redirected from the aorta or internal thoracic artery through the graft to a point distal to the obstruction. This restores oxygen delivery to myocardial tissue that was previously ischemic. What you're seeing in the images on the left side is the gross specimen, so a heart with visible bypass grafts. You can see how the graft vessels sit on the epicardial surface. This is a heart that has been re-engineered. The right diagram shows common graft configurations. Internal thoracic artery is often preferred because it resists atherosclerosis better than veins and has a better long-term patency. The CABG introduces new tissue types into an environment they weren't designed for. So at the microscopic level, veins used as grafts must suddenly handle arterial pressure. Smooth muscle hypertrophy and intimal thickening can occur. Endothelial injury and chronic inflammation are common. Over time, grafts themselves can develop atherosclerosis, they can thrombose, and they can fail, which means repeat pathology is absolutely possible. A fun but accurate analogy is think of this like using a garden hose again to replace a section of steel pipe. It works, but the hose will age differently under pressure. That's essentially what happens when a vein becomes a coronary artery substitute. And why this matters clinically is that patients with CABG often have long-standing cardiovascular disease. They may have multiple interventions over time and can present later with graft failure or new ischemic injury. From a histotech perspective, surgical history matters. Anatomy may not match textbook expectations. Gross examination, orientation, and careful dissection are critical. CABG doesn't cure coronary artery disease. It restores blood flow to save the myocardium. And every graft leaves behind structural changes and histologic clues, a timeline of disease progression written into the tissue. So whenever you hear status post CABG, translate it to altered anatomy, mixed vessel biology, and a heart that has already survived a major insult. That mindset will make you a stronger histotechnologist and a better diagnostician. Now this slide shows the same disease process at two different scales, gross anatomy on the left and histology on the right. And together they tell the story of what happens when myocardial tissue is starved of oxygen. A myocardial infarct, or MI, occurs when blood flow through a coronary artery is abruptly reduced or completely blocked. most often by a ruptured atherosclerotic plaque or a superimposed thrombus. And no blood flow equals no oxygen, which equals irreversible myocyte injury. Once cardiac muscle dies, it does not regenerate. So on the left here, this left image is gross pathology, and this is a transverse section of the heart showing an area of infarction. Grossly infarcted myocardium often appears pale, soft or mottled, poorly contractile, and weaker than surrounding tissue. Over time, this area will be removed by inflammatory cells, replaced with fibrous scar tissue. That scar keeps the heart intact structurally, but it does not contract. On the right, we have the histology images. This is where you all shine. This microscopic image captures the acute inflammatory phase of an MI. So what we're seeing is necrotic cardiomyocytes. We have loss of nuclei, hypereosinophilic cytoplasm. You see all that pink there. Neutrophils infiltrating between muscle fibers. And this typically corresponds to 1 to 3 days post infarct, so post MI. Why neutrophils? Well, neutrophils are the body's first responders, right? They arrive quickly, they release enzymes, and they break down dead tissue. Is that helpful? Yeah, absolutely. But they also weaken the myocardium during this window. This is why cardiac rupture risk peaks a few days after an MI. Think of the infarcted area like a burned section of a building. Neutrophils are the demolition crew. They remove unsafe structures, but until reconstruction happens, the area is fragile. The heart is literally under renovation while still in use. Cardiac muscles do not die quietly, so look for wavy fibers early, loss of cross striations, dense neutrophilic infiltrate, and then later on we'll see macrophages, fibroblasts, and then collagen scar. And this slide tells you when the infarct occurred. This microscopic damage explains why patients may develop arrhythmias, heart failure, ventricular aneurysms, and sudden cardiac death. The electrical system runs through the myocardium, and so scarred tissue disrupts the conduction. And again, not all myocardial infarcts present the same way clinically. Some patients never feel classic chest pain. They present late or are diagnosed only after tissue damage has already occurred. The pathology doesn't care about stereotypes. Ischemia looks ischemic at the cellular level. So bottom line, a myocardial infarct is not just a blocked artery. It's a timeline of tissue death, inflammation, and repair written directly into the myocardium. And as histotechnologists, you're the ones who make that story visible. Okay. We've talked about myocardial infarction as ischemia, turning into necrosis, inflammation, and then scar. And this slide focuses on what happens when that process is extensive, is poorly healed, or structurally destabilizes the heart. These are secondary complications, not the initial cause, but they dramatically increase morbidity and mortality. We have ventricular aneurysm. The ventricular aneurysm forms when a large infarcted area heals with thin fibrous scar tissue. That scar bulges outward with each contraction. Histologically, normal cardiac muscle is replaced by dense collagen. No contractile fibers remain, and the wall is weak and non-functional. Think of it like a blown out tire on a car. The wheel still turns, but it's unstable and insufficient. Clinical impact of that would be reduced cardiac output, arrhythmias, and thrombus formation due to the blood stasis, right? Then we have endocardial thrombus formation. So after an infarct, the endocardium overlying dead myocardium becomes rough and damaged. Blood doesn't flow smoothly. Platelets and fibrins stick. This is Virchow's triad in action. So endothelial injury, abnormal blood flow, and hypercoagulability. As you'll often see laminated thrombus adherent to infarcted myocardium, especially in the left ventricle. Then we have myocardial rupture, which is the big one. This is one of the most feared complications of an MI. Why it happens? The neutrophils and macrophages digest necrotic tissue. The wall becomes soft before scar tissue is laid down. The peak risk is 3 to 7 days post-MI. If the rupture occurs, blood rapidly escapes into the pericardial sac. This is not subtle, it is catastrophic. Cardiac tamponade. Cardiac tamponade results when the hemorrhage fills the pericardial sac. The heart cannot expand during diastole. The cardiac output drops abruptly. From a pathology perspective, the heart itself may look structurally intact. The problem is external compression. So analogy, it's like trying to inflate a balloon inside a rigid box. It physically can't fill. Then we have the mural wall thrombosis. A mural thrombosis forms along the ventricular wall, overlying an infarcted area. The danger isn't just local, it's embolic. It's if part of the clot breaks off, it can go to the brain and cause a stroke, or it can go to the kidneys and cause a renal infarct, or even to extremities where we would have acute limb ischemia. This is why post-MI patients are often placed on anticoagulation. So why this matters for histotechnologists? These complications explain sudden deterioration days after an MI, unexpected deaths, and embolic events with no prior vascular lesion elsewhere. At the slide level, you may see scarred myocardium, adherent thrombus, wall thinning, or evidence of rupture or hemorrhage. So you're not just looking at damage, you're seeing mechanical failure of an organ. And remember, large destabilize the entire heart. And these complications are the reason why timing, extent, and healing of myocardial injury matters so much. Now, this slide is a classic example of the infection is gone, but the damage isn't. Rheumatic heart disease is not caused by bacteria living in the heart. It is caused by the immune system getting confused. Rheumatic fever equals hypersensitivity reaction. Rheumatic fever is a type 2 hypersensitivity reaction, meaning antibodies meant to attack a pathogen accidentally attack the body's own tissues. Some key organs that are involved is the heart, so myocarditis and valvulitis, joints, arthritis, sometimes skin and nervous system. This is why rheumatic fever is considered a systemic inflammatory disease, not just a cardiac one. The trigger is a group A beta hemolytic streptococcal infection, usually untreated or inadequately treated pharyngitis or strep throat. Important context here is now uncommon in developed countries due to rapid testing and antibiotics, but it's still a major cause of acquired heart disease in children in low resource settings. So this disease has a strong global health and equity component, which matters clinically and ethically. This diagram on the right shows the heart of the problem, literally. Some streptococcal proteins, they look structurally similar to proteins in cardiac muscle, and valves, and connective tissue. The immune system makes antibodies against the strep antigen. But those antibodies also bind to heart proteins and trigger inflammation and tissue injury. It's like issuing a wanted poster that accidentally matches someone innocent. The immune system arrests the wrong target. So what happens in the heart? Initially, we get myocarditis, or inflammation of the heart muscles, or valvitis, inflammation of the valve leaflets. Over time, that repeated inflammation, leads to fibrosis and scarring. The valves become thickened, rigid, and misshapen. The mitral valve is most commonly affected, followed by the aortic valve. Histologically, in acute rheumatic fever, we would see interstitial inflammation, the Aschkoff's body, which are granuloma-like lesions, activated macrophages. These would be cells with these caterpillar-like nuclei. In chronic rheumatic heart disease, we'd see dense collagen replacing normal valve tissue, and then fusion of valve commissures, shortened, thickened chordae tendineae. And this is an inflammatory injury turning into permanent structural damage. Patients may feel fine after the strep infection resolves and develop symptoms years later due to valve dysfunction. Some common outcomes are mitral stenosis or regurgitation, heart failure, and need for valve replacement. Rheumatic heart disease is a reminder that immune responses can be just as dangerous as infections. And from a pathology standpoint, it beautifully illustrates how molecular events can cause tissue injury and then cause organ failure, and why early treatment of simple infections matter. And this slide is where we pull everything together, cause, damage, and downstream effects, and see how A childhood infection can echo across decades. So rheumatic heart disease starts as a hypersensitive disorder, not a direct infection of the heart. So what's happening? Antibodies made against the group A streptococcus cross-react with antigens on heart valves. This is classic molecular mimicry. Important clarification here is that bacteria are not in the heart. The immune response is doing the damage. Repeated or untreated strep infections increase the risk, which explains why this disease is less common in developed countries, but still prevalent where access to antibiotics is limited. The hallmark lesion here is scarring of the heart valves, especially the mitral valve, which is technically bicuspid. Over time, inflammation leads to fibrosis, thickening of valve leaflets, fusion of the commissures, and then shortened stiff chordae tendineae. Some functional outcomes could be mitral regurgitation, where the valve doesn't close properly, aortic stenosis, where the valve can't open fully. Think of a valve that used to be a soft, flexible door. Now it's warped, stiffed, and doesn't swing right. Microscopically, chronic rheumatic disease shows those dense collagen replacing normal valve tissue, loss of normal layered valve architecture, and evidence of repeated injury and repair. This is a great example of chronic inflammation turning into fibrosis, turning into permanent dysfunction. Because the mitral valve is usually affected first, pressure backs up into the left atrium. That leads to left atrial dilation and hypertrophy, increased pulmonary venous pressure, pulmonary edema, which is fluid in the lungs. And then clinically, this presents as heart murmurs, shortness of breath, fatigue, and progressive heart failure. Damaged valves are perfect landing sites for bacteria. Why? Roughened surface, abnormal blood flow, and then that turbulence promotes bacterial adherence. So patients with rheumatic heart disease have an increased risk of infective endocarditis, especially during bacteremia. Rheumatic heart disease is a disease of time and memory. The heart remembers an infection, the patient may not. From a pathology standpoint, it beautifully illustrates immune-mediated injury, chronic inflammation, structural remodeling, and those long-term functional consequences. Okay. This slide is where cardiology, microbiology, and pathology all collide, and unfortunately, the heart tends to lose. We're talking about infective endocarditis. So it starts with bacteremia, so bacteria circulating in the bloodstream. Common pathways include like routine bacteremia, so dental work, skin infections, procedures, IV drug use, especially with contaminated needles, and then pre-existing valve damage, such as rheumatic heart disease, congenital valve abnormalities, and prosthetic valves. Normal valves are smooth and slippery. Damaged valves are rough, and bacteria love rough surfaces. The defining lesion is infective endocarditis, is vegetation. Vegetations are clumps of bacteria, fibrin, platelets, and inflammatory cells. They form on valve leaflets, chordae tendineae, or previously scarred or abnormal endocardium. Grossly, they look friable, shaggy, and destructive. The image here shows actual cusp destruction of the aortic valve. Think of vegetations like infected barnacles. They attach, grow, and slowly eat away at the structure underneath. Microscopically, vegetation show dense fibrin layers, bacterial colonies, and neutrophils and inflammatory debris. These lesions are poorly penetrated by antibiotics, which is why treatment often requires weeks of IV antibiotics or surgery. Because this is an active infection, patients often present with fever, leukocytosis, and positive blood cultures. Cardiac effects you may see are new or changing murmur, progressive valve destruction, and heart failure. Some systemic effects: pieces of vegetation can break off and cause an emboli. Those emboli can travel to the brain, the kidneys, the lungs, and the spleen. This makes infective endocarditis a multi-organ disease, not just a heart problem. From a pathology standpoint, infective endocarditis is important because it explains sudden valve failure, it explains septic emboli found at autopsy, and it often overlaps with rheumatic heart disease, which we just discussed. It's also a great example of how structural damage leads to altered blood flow, which leads to infection and then leads to systemic catastrophe. Infective endocarditis is not subtle, not localized, and not forgiving. It's loud clinically, dramatic grossly, and dense histologically, and dangerous systemically. And once it starts, it tends to accelerate quickly. Myocarditis literally means inflammation of the myocardium, the muscle layer of the heart. Unlike myocardial infarction, this is not primarily a blood flow problem. This is an inflammatory injury to cardiac muscle itself. That distinction matters. The myocardium is responsible for contracting, generating force, coordinating electrical conduction. So when inflammation disrupts that tissue, the contraction becomes inefficient, electrical signaling becomes unstable, and the heart may fail even without blocked arteries. The most common causes of myocarditis are infectious, especially viruses, which is the most common overall. So the Coxsackie virus is the classic board favorite. Bacteria, fungi, parasites. In addition, myocarditis can be caused by drugs, including some chemotherapies and toxins, immunologic disorders where the immune system attacks cardiac tissue. Anything that triggers inflammation inside cardiac muscle can impair heart function. Histologically, myocarditis typically shows inflammatory cell infiltrates between myocytes, myocyte injury or necrosis, often patchy involvement, so not a single well-defined lesion. This patchy pattern explains why symptoms can be unpredictable and arrhythmias are common. Myocarditis can present in very different ways. Onset may be abrupt, so sudden symptoms, or insidious, so slow, subtle progression. Common manifestations include impaired myocardial contraction, chest pain, which is often mistaken for an MI, arrhythmias. An important point here is that a young patient with chest pain and arrhythmia, but normal coronary arteries, should raise suspicion for myocarditis. So a big picture comparison here, myocardial infarction leads to ischemic injury. Endocarditis is infection of the valves, and myocarditis is inflammation of the muscle, right? 3 different mechanisms, 3 very different pathologies, but all can end in heart failure if severe. So take home message here, myocarditis is dangerous because it weakens the heart muscle directly, it destabilizes electrical conduction, and it may progress silently before becoming severe. And unlike MI, there may be no warning from blocked vessels. Hypertensive heart disease is a chronic adaptation problem that eventually becomes a failure problem. At its core, this disease is about workload. Why hypertension matters to the heart is that when someone has long-standing high blood pressure, the heart has to pump against increased resistance every single beat. Think of it like lifting a heavier weight over and over. The muscle adapts by getting bigger. In the heart, that adaptation is cardiac hypertrophy, particularly of the left ventricle, which is doing the majority of the work to pump blood into systemic circulation. Initially, hypertrophy is compensatory, so thicker myocardium, stronger contractions, ability to maintain cardiac output. But over time, the thickened muscle becomes stiffer, relaxation during diastole is impaired, filling becomes less efficient. This is where the problem starts to snowball. Oxygen supply versus oxygen demand, and this is the key concept on this slide. As the muscle mass of the heart increases, its oxygen demand increases as well. However, coronary arteries do not automatically enlarge to match that demand. If coronary arteries are already atherosclerotic, oxygen delivery becomes even more limited. So now you have a heart that needs more oxygen, blood vessels that cannot supply enough. And that imbalance puts the myocardium at risk for ischemia and ultimately myocardial infarction. Many patients with hypertensive heart disease may not have chest pain initially, and they may not know they have significant cardiac hypertrophy. They can appear stable for many years, but structurally the heart is under constant stress. The risk for heart failure, arrhythmias, and infarction steadily increases. So the image on the right here shows an enlarged heart, thickened ventricular walls, and excessive epicardial fat often seen in chronic cardiovascular disease. This is a heart that has been working too hard for too long. Big picture takeaway is that hypertensive heart disease is driven by chronic pressure overload, leads to cardiac hypertrophy, increases oxygen demand, and then raises the risk for myocardial infarction and heart failure. And importantly, this disease is preventable and modifiable, but only if hypertension is recognized and treated early. Cor pulmonale literally means heart from the lung. That phrase alone tells you the entire story. Cor pulmonale is right-sided heart disease caused by pulmonary disease driven by pulmonary hypertension. It is not caused by left-sided heart failure or primary heart disease. Chronic lung disease, so COPD, interstitial lung disease, pulmonary fibrosis, chronic hypoxia, etc., these all lead to increased pressure in the pulmonary arteries. The right ventricle now has to pump against higher resistance. The right ventricle responds with hypertrophy. Over time, the right ventricle fails. That progression, pulmonary hypertension, leads to right ventricular hypertrophy, then leads to right heart failure, is what we call cor pulmonale. The right ventricle is designed for low pressure circulation. It has a thin wall, and it is not built to handle chronic pressure overload. So when pulmonary pressures rise long term, the right side loses the ability to compensate. Although not listed on this slide, cor pulmonale commonly presents with peripheral edema, hepatomegaly, ascites, and jugular venous distension. These are classic right-sided heart failure signs. This is an important mental divider. Left heart failure equals pulmonary congestion. Pulmonary disease equals right side heart failure, or cor pulmonale. The lung is the primary driver, not the heart. Cor pulmonale is a secondary heart condition. It's caused by chronic pulmonary disease, characterized by right ventricular hypertrophy and failure. If the lung disease isn't addressed, the heart cannot recover on its own. Okay, before we dive in, remember this big picture definition. Cardiomyopathy is a disease of the heart muscle itself, not valves, not arteries. The myocardium is the problem. Think of the heart as a pump made of muscle. Cardiomyopathies are different ways that muscle can become too thick, too stiff, too weak and stretched. Okay, so we have hypertrophic cardiomyopathy. This is caused by a genetic defect in proteins of the contractile apparatus. It most often affects the sarcomere proteins, so actin, myosin, troponin related machinery. For histologically, we'd see myocyte hypertrophy, disorganized myofibers, aka myofiber disarray, thickened interventricular septum. Histologically, it looks like someone shuffled the muscle fibers instead of lining them up nicely. An analogy here would be this heart is like a gym bro who never skips leg day but refuses to stretch. So we'd see huge muscle, poor relaxation, and bad filling. Fun fact, this is a common cause of sudden cardiac death in young athletes. The muscle is powerful but electrically unstable. Then we have restrictive cardiomyopathy. The heart muscle becomes stiff, not thick, and not dilated. We'd see that from radiation fibrosis, amyloidosis, deposition of metabolic byproducts, so inborn errors, iron deposition, hemosiderosis. Histologically, we'd see interstitial fibrosis and some extracellular deposits. So amyloid, we'd see that amorphous, eosinophilic extracellular material. Iron, we'd see coarse granular deposits, and that would be Prussian blue positive. The myocytes themselves often look relatively normal, but they're trapped in concrete. Analogy for this would be open anymore, so the chambers can't fill. The diastolic dysfunction dominates. Worthless but useful trivia. Amyloid shows apple green birefringence under polarized light with Congo red stain. It's pathology's favorite party trick. And lastly, we have dilated cardiomyopathy, where the heart chambers become enlarged and floppy. Systolic dysfunction is the big issue here. Could see that from alcohol toxicity, pregnancy associated, so peripartum. It could be genetic, or we could have a diffuse ischemic injury. Histologically, we'd see dilated chambers, thin ventricular walls, the myocyte stretch and degeneration, patchy fibrosis may be present. This is the cardiomyopathy you can often identify grossly because you even look at before you even look at a slide. Analogy, this heart is like an overstretched rubber band. still exists, but it can't snap back effectively. A clinical pearl here is that alcohol-related dilated cardiomyopathy is dose and duration dependent. This is chronic toxicity, not a single bad weekend. Okay. So how to remember them? So hypertrophic is too thick, they can't relax. Restrictive is they're too stiff and can't fill. And then dilated is they're too stretched and can't pump. Cardiomyopathies are diseases of muscle, again, not valves or vessels. They are defined by structure and function, and they're best understood by linking gross appearance, histology, and physiology. Atrial fibrillation, often called AFib, is not a problem of muscle strength. It's a problem of coordination. In atrial fibrillation, the atria are not contracting in an organized way. Instead of smooth, coordinated squeeze, the atrial myocardium quivers. Electrical impulses fire rapidly and chaotically. The atria do not meaningfully contribute to ventricular filling. That's why the slide says quivers rather than beats. Electrical chaos equals clinical symptoms. Because electrical signals are transmitted irregularly to the ventricles, the heart rate becomes irregularly irregular. The ventricular filling varies beat to beat. This leads to faintness, dizziness, weakness, palpitations, and even sometimes chest pain. Think of the atria as the opening act for the ventricles. In AFib, the opening act never shows up on time or at all, so the main performance suffers. One of the most important consequences is incomplete emptying of the atria. When blood doesn't move, it stagnates, especially in the left atrial appendage. So stagnant blood and endothelial contact equals a thrombus formation. These are often mural thrombi. They can detach and become emboli. Once they enter systemic circulation, they can cause a stroke. This is why AFib is one of the most important risk factors for embolic stroke. AFib contributes to congestive heart failure in two ways: a loss of atrial kick, which is reduced ventricular filling, and then persistent tachycardia, which is increased myocardial oxygen demand. Over time, the ventricles simply can't keep up. Atrial fibrillation is dangerous not because the heart stops, but because it loses efficiency, loses coordination, and creates conditions for clot formation. One last worthless but useful fact: the phrase irregularly irregular is practically reserved for atrial fibrillation in medicine. This slide answers the question, what happens when the heart can no longer do its job? The short answer is that every other organ pays the price. We have something called cardiogenic shock, which is pump failure. So the heart cannot generate enough cardiac output to meet the body's needs. That means inadequate oxygen delivery, tissue hypoxia, rapid progression to multi-organ failure if not corrected. This isn't a plumbing backup yet. This is not enough pressure leaving the heart. So think massive MI or severe cardiomyopathy and even end-stage arrhythmias. Then we have the congestive heart failure. So it is a flow problem, not a total pump stop, right? The heart is beating, but inefficiently. Blood backs up because it can't move forward fast enough. Left-sided heart failure, or panel A. This is when the left ventricle fails, blood backs up into the lungs. Result here, we'd have pulmonary edema or pleural effusions and shortness of breath. Histologically, in the pulmonary capillaries, we'd see increased hydrostatic pressure, fluid leaks into alveolar spaces, and then gas exchange becomes impaired. This is why patients feel like they're drowning on dry land. Right-sided heart failure, or panel B. When the right ventricle fails, blood backs up into the systemic venous circulation. The results are distended neck veins, hepatosplenomegaly, ascites, peripheral ankle edema. Because venous blood can't drain efficiently, the liver becomes congested, so are the sinusoids dilate, and over time that becomes congestive hepatopathy. So if you see pulmonary edema, think left-sided failure. If you see hepatosplenomegaly and peripheral edema, think right-sided failure. And this slide links back to myocardial infarction, cardiomyopathy, hypertension, valvular disease, atrial fibrillation, cor pulmonale, different causes, but the same endpoint. Think of the heart as a traffic control hub. Cardiogenic shock equals the traffic lights go out entirely. Congestive heart failure equals massive traffic jam. Cars still moving, just not efficiently, and everything backs up. Big takeaway here is that heart disease doesn't stay in the heart. When the heart fails, the lungs flood, the liver enlarges, the legs swell, the brain starves, and the kidneys shut down. Organ failure is the final common pathway. And a final memory hook is forward failure is shock and backward failure is congestion. If you remember that, this entire slide makes sense. Okay. Up to this point, we've talked a lot about how a heart fails. This slide answers the next logical question students always have. Okay, so what do we do when it gets this bad? Short answer, at end stage heart failure, we replace or bypass the pump. So that would mean heart transplantation, and this is the gold standard for end stage heart failure. And yes, this is exactly what it sounds like. You remove the failing heart, you replace it with a donor heart, restore adequate cardiac output and oxygen delivery. This is not for mild cardiomyopathy or early CHF. Let's see how meds work. This is for hearts that are structurally damaged, functionally exhausted, and no longer able to meet the body's oxygen demands. Transplants are limited by donor availability, immune rejection, and lifelong immunosuppression. So while it's a brand new heart, it's not a cure, it's a trade-off. We also have left ventricular assist device, or the LVAD, LVAD. Think of it as a mechanical coworker for the left ventricle. An LVAD siphons blood from the left ventricle, pumps it directly into the aorta, essentially does the job the failing left ventricle can't do anymore. Key concept is the heart is still there, it's just being helped. So why the left ventricle? Because histologically and functionally, the LV has the thickest myocardium. It generates the highest pressures. It's the chamber that fails the most catastrophically in cardiomyopathy, ischemic injury, and hypertension-related diseases. And when the left ventricle fails, everything downstream suffers. The organs become hypoxic, chronic heart failure and shock follow, and then the LVADs step in before total collapse. LVADs can be a bridge to transplant, a bridge to recovery, or destination therapy when transplant isn't an option. A fun but slightly unsettling fact, many LVAD patients do not have a palpable pulse because the blood flow is continuous, not pulsatile. Yes, you can have a living patient with no detectable pulse. Think of heart failure like a failing engine. Medications equal tune-ups, stents and bypasses equal cleared clogged fuel lines. An LVAD is installing an auxiliary engine, and then transplant is swapping the entire engine block. At this stage, oil changes aren't fixing the problem anymore. These treatments exist because cardiac tissue does not regenerate. Necrotic myocardium becomes scar. Scar does not contract. And once enough myocardium is lost or dysfunctional, then mechanical or surgical intervention is the only option. So when muscles fail, mechanics step in. That's the logic behind the LVADs and the transplants and end-stage heart failure care. All right, I've talked a lot and we've covered a lot. So we've covered congenital heart defects, ischemic disease, cardiomyopathies, arrhythmias, heart failures. If your brain feels like it just ran a marathon, that's completely normal. This slide isn't just any questions before we move on. This is your chance to ask for clarification, revisit something that didn't quite click, or connect the histology to pathology. Or, if you're confused, chances are someone else is too. They're just being quieter about it. Their friendly reminder that there are no bad questions, no I should already know this questions, and absolutely no judgment here. Pathology is about pattern recognition, and patterns take repetition. So if you remember nothing else from this lecture, remember this: structure drives function, and when structure is altered, failure follows. That applies to myocytes, valves, vessels, and the heart as a whole. Remember, histology isn't just slides. It's explaining why patients get sick. And finally, if you have questions and they come later, which I'm sure they will, write them down, email me, or bring them to the office, the Zoom office hours. You can always revisit this lecture and pause where needed. And that's how learning actually happens. So I apologize for talking so long, but this was just a lot of very important material.